Okay. Let me create a bit of a breadcrumb trail from our last meeting. Those of you that will remember, again, I'm Roger Chaufinier. I'm one of the consulting teams supporting the collaborative. We had suggested as part of the design, one of the critical success factors in all improvement efforts is the role of leadership. And rather than starting a whole separate leadership track, that we weave leadership into this meeting with much more of an applied focus. The design was intended to, each time we meet, to introduce a little bit of leadership content in terms of sharing some best practices and what's working and things to remind you of as you help oversee your efforts in your organizations, and then put our energies on really design, where can we improve the environment. At the last meeting, we talked, we reviewed some of the data from the state in terms of how the four-county region here compares to the rest of the environment. We identified two areas where we seem to perform in the rear, if you will, compared to the rest of the state. Our numbers are not as strong as others. So one was in the area of asthma. The other two were follow-up post-discharge patients. And so those two distinct areas suggested was an opportunity for us to work on. So today I'm going to introduce a short amount of content based on some requests from the field to talk a little bit about sustaining and spreading change and how do you do that. And then we're going to dive into asthma. We have a little bit of data. We'll talk about what more data. And then we'll do a little bit of an environmental scan and try to pull out of view what assets and resources exist in the environment we might be able to leverage. And then talk about some next steps as we plan for moving into December and January, February, what we might do with asthma. So I'll come back to that. So let me start with talking about sustaining and spreading change. Leading, sustaining, and spreading change is probably one of the most challenging things of senior leaders, one of the most important roles that we can play. It's also one we take for granted. One of the traps of leadership is that we believe the traditional hierarchical model where we cascade information down through the organization result in change, and result in people getting the message. I was with a group on Friday, and they have a relatively new email system that they put in, and they have a weekly newsletter that they send out to the organization to give updates. And I got great feedback from the staff on this weekly newsletter. But when they actually look at the data, less than 50% are opening the email, right? And people are saying, I didn't get the message. Why am I not getting the message? Well, that was their principal way of just cascading down through the organization. So really understanding how do people really learn, how do they adapt change, how do they move forward is what we're going to be focusing on. So one of my profound lessons came in this needle stick example when I was a hospital administrator in the 80s. I was walking down the hallway of my hospital and there's a nurse crying. And I said, Jerry, what's wrong? And she was one of heart and soul of the organization. She said, I'm quitting. I can't take it anymore. I said, what's wrong? She said, I'm on 5 needle stick committees. We were a regional aid center with the outbreak really just hitting. And one of the challenges is our staff are getting infected as a result of needle sticks. So it was a really, really serious incident. And I said, 5 needle stick? I mean, you mean you're at your 5th meeting? And she goes, no, there are 5 committees working on this. I staff them all. I can't take it. I'll talk about the same thing. Blah, 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 blah. I said, this is ridiculous. It's over. Tell me what the solution is. She said, we need needle boxes in every patient room. Jerry, it's done. Call up my plant manager. I said, this is like a Tuesday. It's about Friday afternoon. I want needle boxes in every patient room. They were up in every patient room by Friday afternoon. What happened to the incidence of needle sticks in my hospital as a result of that? Went down? Skyrocketed. They installed these opaque red boxes, put them up too high on the wall, where people were sticking themselves, putting the needles in the box than our practice. I also added $25,000 of operating costs to handle this new needle box program in the organization. And I said, how can this happen? And then I started learning a little bit about how change actually happens in organizations. This is the famous Everett Rogers diffusion of innovation curve. Now, change is a process. There's lots of people, lots of theorists out there that have described change. Kotter out of Harvard, and Oski, and Kurt Leuven, and others. But they all suggest that change is a process, and we in leadership forget the process steps. Kurt Leuven has a wonderful model that he talked about, that in order for there to be change, you first have to unfreeze people. You can't just go plot change on people. In fact, one of the key drivers of intrinsic motivation, which is a sustainable motivation, is the ability to control the variables around your life. When change is imposed on people, they push back. And a lot of it is because they fear the unforeseen consequences of what change is going to bring. They don't know what this is about, where did it come from, and it's nothing but bad news for me. And we see that with our care teams. We put on new measures. We have alert fatigue with our EMRs, where we're constantly dumping more and more on our care teams, and the care teams are pushing back saying, I've had it, I'm in overload. You know, what is this all about? And a lot of it is out of context. So you have to first unfreeze the change. The second is that you have to then give them new tools and methods of what to do about it. And be very specific about the change you're trying to make. And the third stage of the change process is refreezing. Make it very difficult to go back to the old way. That's a pretty simple model to think about. What do you have to do to unfreeze? Create the tension for change. What do you have to do to give direction? And then what do you have to do to refreeze? Now, I wish it was as simple as a model like that. But the reality happens is that change is a social process. And there's a lot of evidence about how change takes place in the environment. So from the time a change is offered to an environment or system to when it hits the midpoint of being accepted by the environment, 14 to 17 years, according to the original research done by Everett Rogers and validated by the Agency for Healthcare Research and Quality in Healthcare, by Deloitte Touche, by others. So when something appears in JAMA or New England Medicine or some new therapeutic comes out, the time it comes out, when it hits the mainstream, takes about 14 to 17 years. And all of a sudden, it takes off like a rocket. So there have been studies to figure out why is that? What is actually happening that is causing this kind of crazy phenomenon? And what they found is this diffusion curve. And many of you have heard the term, the early adopters. You know, go after the early adopters. Well, Everett Rogers studied the introduction of seed corn in Iowa. And they had developed a new seed corn that was drought and pestilent resistant, had a higher yield of corn per acre than any corn before. So they introduced it in the community, and then they waited to see how long it hit the mainstream. And at 14 to 17 years, it just was growing like this, and all of a sudden it took off. But there were a handful of farmers that never changed. And they went and talked to those farmers, why won't you change? And they said, well, you know, this seed corn's been in my family for hundreds of years. We're not changing. This is our seed corn. I don't care what it does, you know, it's not that important to me. What they found, though, is that when you hit the early adopters, there's a group of pioneers that introduces the new idea, the change. Some of you are pioneers in your environment. You introduce a new change. The challenge with pioneers is often they're looked at by their peers as whack jobs. They're looked at as these, you know, strange folks. I'm affiliated with Hopkins, and we have a couple of real whack jobs on our faculty. One guy's been living in his office for 30 years. Lives in his office. That's his home office. A brilliant hematologist. But one strange guy. Okay. Tremendous bench research coming out of his lab. New approaches, wonderful. Right? Everybody looks at him like, wow, he's out there, right? There's a group called the early adopters that are the ones that are always looking for competitive advantage, looking for one step up, one way to get ahead. And they watch what happens with a new innovation, and they usually calibrate it off of someone else using it. And once they convince themselves, then they start using it. That makes up about 13.5% of the population, the pioneers of the 2.5%. So it's about 15% of the population total. If you can get 20% people using the new approach, the new change, and it is almost impossible to stop that change from hitting. And that's where you see a hockey stick takeoff. So you'll see in this slide, there's a long progress here, and then all of a sudden there is a hockey stick explosion. This was in the adoption of the chronic care model introduced by Ed Wagner and his team at Group Health of Puget Sound. They introduced that back in the early 80s, and it didn't hit the mainstream in primary care. It still hasn't been fully adopted across the environment in the 1990s. Now, the implications of this on change is we spend all of our time trying to convince the traditionalists, those laggards, those poor farmers that said, I'm not using that corn. And they are often their leaders in the community. They're often people whose opinion people respect. Oh, Charlie's been around forever. I mean, he knows how to farm like crazy. I mean, you better pay attention to what Charlie says. If he doesn't like it, there's got to be something there we ought to think of. So in leadership, we spend all of our time trying to convince the naysayers, and it's emotionally taxing. It takes a tremendous amount of selling, and in the end, they may never change, never buy into it. So it keeps us from moving forward. So what the lessons from this are, if you can focus on those early adopters and burn in your change, start with one early adopter, and then go to the next early adopter, then go to the next. You will accelerate your change to the point where that becomes the mainstream way of doing it, and then you can put in the long-term sustainable pieces you need, policies, procedures, other things that go along with that. So an example of that, I don't know how many of you have written policies and send them out to the organization, and they're giant belly flops. And we usually have not tested the policy. We have, just like my noodle sticks, we didn't test on one unit to see if it would work, the bugs. We do this broad shotgun, and then when it doesn't work, we spend all this time trying to convince the resistors, and eventually we just often give up. Lesson is to start with the early adopters. I'll get to your question in a second. Burn it in, and then put your policies in. Question, Dave?
This sounds terribly crass or whatever, but assuming we believe in evolution, why don't we let the traditionalists keep doing the way they do it, and then let them go out of business, or let them be shut down because they're dangerous to patients or whatever? Because some of this stuff is actually patient safety.
Absolutely.
And they refuse to do something different. Don't try and convince.
That's the point.
That's pretty harsh, but
You got the point. The point is, don't do that. Don't waste your energy. The point is, make it work with the early adopters. Make it become part of the mainstream. If it's a real patient safety issue, you have to do a risk management calculation as if they continue that practice, is it going to compromise the organization, therefore a change needs to be made? Or is it not really a risk issue, but it's, they will either commit euthanasia, let them die off, is the bottom line. But put your energy into those that are willing to try it, willing to make it work, willing to burn it in and learn from it, study it, burn it in, and then you're going to find that your pace of acceleration is faster, and your personal anguish is going to be much less. Not having to convince
I realize that I'm an early adopter. So it's easy for me to make some changes and all that kind of stuff. I think sometimes, and I'm not speaking about North Central Washington, sometimes we spend a lot of money in organizations on ventilators and giving them one-to-one nursing care, all sorts of stuff. I just got back from a trip to Oregon. And this is what's happening down there. And I'm not trying to say that the communities this place serves, it's Central Oregon, and I'm not going to say too much more because maybe everybody knows communities there, but resources are being spent trying to make the people with the 100-year-old seed do something different, and maybe you just need to bypass it and give them the information, and then if they refuse to change, Yeah, I mean.
I'd like you to reserve that thinking when we get to the asthma discussion. So, where are the opportunities for us to influence the environment in asthma? Apply those same concepts. Let's not go convince the whole world about what we need to change, but let's go find where there could be some real tests of change that could really influence the numbers and see what we come back to that. Some of you heard Malcolm Gladwell has written his books, and he talks about the tipping point. Well, that tipping point is that curve he's talking about there. It's that early adopter curve. And what's interesting is Gladwell talks about what he called mavens and connectors, right? So there's a company that was bought by Aetna, one of the large insurance companies. It was called ComSort out of Baltimore. And what they did is they mapped every physician in the United States and identified who the mavens and connectors were. So they literally called physician practices and said, who do you talk to if this new antibiotic comes out for kids? Who do you talk to bounce the ideas off? They usually have a subject matter expert, a faculty from their medical school or someone in the community, and then one other colleague they really respect to bounce the ideas off. And what the pharmaceutical companies found, you mapped those mavens and connectors and did your detailing on those folks, sales skyrocket. The early adopters. If you get the early adopters on board and that next group, boom, it takes off like a crazy. Now, in our quality improvement efforts, one of the things we're teaching teams is knowing when to scale your PDSA cycle. This is really, really important for those of you that are guiding improvement efforts in your organizations. All too often, someone will have a winning PDSA. His leaders say, okay, we're going right to scale. Let's just burn it in. I'm sending out a new policy. It's not ready. It hasn't been baked in. It hasn't been tested enough, different conditions to see what's really needed. So we want to see the degree of belief that this change will really stick. Have we tested it in different shifts, different environments, different sites, different conditions, to make sure that it's going to work over time? Each of those has different nuances we need to think about. So, and when a change comes out, if we have a very high belief that this is something that we can just scale very easily, and sometimes there are things that are no-brainers, especially in a patient safety area. I think the last time I was here, I talked about a client, a hospital system that had a sentinel event resulting in death due to breakdown in process with a patient in the hospital getting food that they were allergic to and coded. And they did a RCA, root cause analysis, right that day, the next day. A week later, they had another incident. And that didn't result in death, but another incident. They hadn't put in the changes they need. If it's a serious issue, like you were suggesting, then sometimes you got to go to scale. But you have to have a very high degree of belief that you're ready to do that. So this notion of different beliefs of where we are versus the level of commitment of those in the organization. So if you have a real easy change that is intuitively makes sense to people and there's good, strong evidence, tested and it really works, you have really good buy-in, then that's something you might be able to go to scale. But if you haven't tested that buy-in and pushback through that early adopter approach, then you're likely to run into some buzzsaws of that resistance to change. Very, very important to step back and look at what we could do. So the first piece of the puzzle is, before we spread, is have we put the systems in place to sustain the work? Okay, so you have a new process, a new approach. We're going to test this new care manager role on our care team, or we're going to do this new social determinant screening tool with our staff. And we think the front desk person can implement it. And we've had pretty good success in one clinic with one care team doing this new tool. So that's great. Let's really see how that works. Can we test it now to another care team? Can we test it to another area of the clinic? See what challenges are. It may be all a function of the superstar that's putting it in, but it may not be something that's real easy for others to do. You've got to test it enough to get to the point where you have confidence. And then the question is, what systems do we have to put in place? One of the challenges often in quality improvement is that we start a project and we don't think of the long-term sustainability, and we don't put the reliability systems in place to ensure the success. Cedars-Sinai do some work with, and a meeting with them recently, and someone asked, when do you end projects? And they looked and said, end projects? We never end a project. If it's important enough to start a project, then it's sustained forever. When a project's over, we assign an owner, someone who's responsible for monitoring that process and owns it. And they're going to look at the data long term, and if it starts regressing back to its normal steady state of mediocrity, they're going to jump in and say, we need to make some changes. We need to make sure that things are in place. But for those of you that are accredited by the Joint Commission and others, there's a real focus on reliability theory, high reliability organizations. This is all about the practices of what are we doing to make sure that these things are staying fixed. There's long-term measurement in place. Doesn't necessarily need to be on the corporate dashboard. Maybe it needs to be at the point of service, someone owning it. So if you're working on cycle time in your clinic, often we'll get these huge gains in cycle time coming down, and then we celebrate, and then 9 months later, staff are coming back going, we got a problem with cycle time again. It's like, well, we just worked on that. Right? Well, then it turns out nobody is looking at it on a daily basis. No one is owning it, and no one is making sure that it's staying fixed. So you want to make sure that there's an owner for every process. You have a measure in place. You want to make sure you have all the administrative systems, the training, the collateral material you need, any changes to job descriptions, any of those bureaucratic administrative processes that are necessary to put in place. Then you have to have the system of monitoring compliance. Who's going to do that? Again, better done at the point of service by local staff, giving people a sense of ownership for it. And then where possible, make it very difficult to go back to the old way of doing things. So organizations that put in new electronic record systems and had electronic forms and paper forms, or maybe you're making a change to a form, and you've got a lot of the old stock. People say, well, we'll keep both forms in place if we run out of the old one. Sure way to kill your adoption of your new process. You want to take away the old form and make it very difficult for people to go back to the old way, right? All too often, we're worried about that change process, but not thinking about the long-term pieces. Any questions on sustaining the gains? Any questions on that? So keep in mind that change is a social process. This is a model from the Institute for Healthcare Improvement. And what it suggests is that if we have a new change, a better idea, a new process, that before we spread it through our social system, we need to be really paying attention to the setup. Who are our targets for the next early adoption phase? Where is the evidence base we've created that we can package and show people the impact so they can see that it's observable? Do we have an initial spread strategy? We're thinking through who those next 2, 3, 4 targets are so that we can make sure that that process is in place. This is an assessment model developed by a fellow down in Miami, St. Anthony Amofa, who was with the community health center down there. And what he suggested was that in his organization, they do a pilot team, and they then make sure that they've thought about the alignment with the strategic plan so they can connect the dots for people in the organization. They make sure measures are in place. This was in the case of putting a registry or database in place. Are there staff to support it? Is it going to be sustainable long term? Is that built into the budget? Is there a senior sponsor responsible for overseeing the change, making sure it's staying in place? And they do a little bit of failure mode analysis. Where is it likely to go wrong? What distractions are going to come up to keep this from being in place? So if you know you're about to have an external accreditation review and you're then about to put some changes in, that could be a deal killer. As soon as you're launching it, all of a sudden your accreditors are arriving on site and everything's distracted and people are forgetting what the new changes. So really thinking through the timing of your changes. Leadership's role, one is to make sure that your topics that you're working on and prioritizing are in alignment with your strategic initiatives. Do you have a senior sponsor assigned to oversee the change, make sure it moves through the organization? Is there a frontline day-to-day manager identified for a change that you're trying to put in? And are your goals and incentives aligned in the organization? So are there any of the performance feedback or reward and recognition that would align, support some of these big changes you're trying to make in the organization? As you're planning for spread, should be thinking about that as a design process. Don't take it for granted. Who's your target population you're spreading to, your next provider, your next panel of patients, your next clinic? Was your pilot successful so that if they turn back to the other group and say, well, how did that change work? They could say, wow, huge impact. I'm getting home on time now every day. You should see the numbers that improve for my patients. You should see it's reducing cost. Whatever those metrics are, that they have good, strong evidence. And then really plan who are those early adopters and the initial spread strategy. And try to be thinking through as systematically as you can how you're going to spread it. And looking at patient-centered medical home, let me give you a couple examples. One organization created a pilot team that was applying all the concepts of patient-centered medical home or health home. And that pilot team served as the spread group. And they went care team to care team as a group going and explaining to their peers. So the front desk person explaining to the front desk person, care manager to care manager, physician to physician. These are the changes. This is how we're doing it. They're going on site at opportunity. Another group created a spread clinic where they have their new best practices and invited early adopters in to follow them and shadow them to see how the new workflows will work. This is what the care manager does. This is what other people do along the process. Another organization has a simulation laboratory, and they use that to burn in changes. So they actually do walkthroughs with people to see how you can do the effort. So different approaches, but in each approach, it's a social process. It's getting the staff communicating to the others, packaging the information, targeting who to spread, and then really monitoring, moving it through the environment. Being sure to create the context for why the change is needed, not just plopping the change on people. So you'll notice in the earlier, we talked a little bit about the start of this, and I created a breadcrumb trail from the prior meeting, connect the dots for people. That's a really important function in leadership, that we connect the dots of why we're doing what we're doing. Makes sense to people, create that context. Take advantage of your existing relationships in the organization. You could pretty much map already your early adopters in your organization. If I were to ask any of you, who would you pick for this particular project or initiative? You'd say, oh, I could tell you exactly who. This is the person I would go to as an early adopter. So map those early adopters and look at how you can burn in the change with them. And where possible, we heard here about how these learning and action networks are creating communities of practice, that social benefit of learning from others. You can do that intra to an organization, especially if you have multiple sites or multiple opportunities, multiple care teams. So creating that opportunity for them to collaborate, share with each other is part of the power of the process. Let me stop there and see what questions there are on spread. Any questions or comments on spread? Any great belly flops to share on spreading? I have a whole list I could probably share.
We've got all kinds of belly flops. It's hard. The why, I think you didn't probably emphasize that as much as I think we found the importance of why, explaining the why early on to get people to do things. Because you try all these carrots and sticks to do things, and really it's internal. If they understand and tie into the why, it's so much easier.
Very, very powerful concept. We have, our leadership systems have been trained over the years to focus on extrinsic rewards, punishment, or carrots and stick. And we think that's going to be the reinforcer. It's going to make it happen. The evidence base is there's yet to find a single study anywhere that shows how extrinsic rewards lead to long-term sustained performance. They're all based on the Skinner rat and Pavlovian dog experiments. And people are not dogs and rats. Fear and extrinsic rewards work short-term. The problem is you have to keep applying them and they have an attenuation effect. You have to increase the intensity over time. So when you throw out an initial pay for performance or reward, next time people are saying, well, it's worth a little bit more money than that. I'm not sure unless you get a little bit more. It doesn't have the same effect. As David said, it's really the intrinsic motivation you're trying to bring out. And part of that is the why. It has to make sense to them. It has to have some value and meaning. It has to be connected to a greater good. Want to make a comment on the phone?
This is Doug Wilson. Can you guys hear me?
Yes?
One thing I notice is that we at Confluence particularly have such a proliferation of initiatives, and also I guess what I'd say is the ecosystem that we providers live in is changing so quickly. You know, the EMR is different than it was 6 months ago, and so these projects not only need to be sustained, but they need to adapt with us and continue to become more and more usable and less burdensome, rather than the default, which would be that they become more burdensome and obsolete because everything else in our practice environment is changing so quickly. So I think it really requires determined focus on making sure these important projects stay relevant and usable.
Great observation. So one of the key things from a leadership perspective is to make sure your projects are relevant. We have lots and lots of projects that we've piled onto people. Some of them feel like appointments for life. You know, they're working on them 3, 4, 5, 6 years, and they're not making progress. Highly recommend you consider committing euthanasia for those long-term projects that are not making progress. Kill them.
Absolutely.
Start all over. Staff will really appreciate that you're not wasting their time. And find a new group that may have the energy and different lens and perspective and execute on it. Secondly, if we do have a lot of projects, sometimes the environment forces us that we can't do things in a linear fashion. We have to do many things at the same time. The more you can democratize that and pushing it down and delegating it, supporting it, rather than putting it on the shoulders of a limited few in the organization, then you can really scale in a much more concerted effort. But it requires tracking it. Requires having a senior sponsor assigned to it, having the good metrics you're following, and a communication system that you're feeding back so people can see that all this change is heading towards a better state, that we're actually making a difference here, that we're moving things forward in a better way. Other comments or observations?
I get what you're saying about the change, and how does that relate to really tiny organizations? When you only have 4 people doing whatever it is, you can't switch and move and, either do it or you don't.
Literally.
So one thing is suggested earlier is look for things that are not adding value, and can you get rid of them? Are the things that you're just doing that are just not having the impact and value? And then they're not connected to an external need where you have to do it for accreditation or licensure or whatever, but something you've imposed on yourself or the team. A good example is frequency of meetings. Over and over again, every organization I go to, we have too many meetings. You want us to do all this work, and 80% of our week is in meetings. When are we going to find the time to do this? All right, can you cut your meetings in half? If you're having a weekly meeting with a direct report, do a content analysis of that. What percentage of the time is value added? Put it every 2 weeks. You freed up an hour a week. If you have 6 reports, that's 6 hours a week. And now in a small organization, you don't have a lot of direct reports. So is there any work you can get rid of? 1. 2, how can you start to take your work and boil it down into a series of sprints? Create a parking lot of things to do and focus on a small number and execute them brilliantly. And then pull out of your parking lot the next one and execute. What we do is we just add, and then it's so overwhelming, and then we don't execute any of them brilliantly. So if you can focus your energy, then execute. Notice the very large companies, Hewlett-Packard, Microsoft, Apple, they're coming out with one blockbuster product a year, one major new upgrade. They're not coming out with this Sears catalog of products for you. Sometimes it's a couple. They focus. They put tremendous amount of resources on executing brilliantly. By the time they're ready to launch, they've already field tested it with people. They've already fleshed out how are early adopters dealing with this. What are the prospects of being able to go to scale with that? So take those same concepts. Let's focus on a small number of priorities, execute them, create them where possible into sprints, and then move on to the next one. Find that your pace of execution will increase, and it'll be less overwhelming for the collective team. Does that help? Yes, ma'am.
What about pausing? So this is always moving forward. Have you ever experienced where it's advantageous to just say, we're going to stop and not change anything for a little while?
Yes. That's a function of where the organization. One of the things organizations often don't do well is stop, pause, and celebrate. Acknowledge the progress, reflect on where we are, how is this having an impact on what we're doing, and recharge the batteries and set the next planning horizon. So where possible, moving your work life into a series of targeted work over a specified time, and not just this open-ended, never-ending journey. Then pausing, reflect, take a break, take a breather, review the measures, review where we are, celebrate the successes, do some failure mode analysis. How are we building sustainability? And now let's work on the next activity or next sprint. Does that help?
Yeah, thank you.
Any other comments or questions? Make the offer. If you have any individual circumstances you want to shoot me an email. I'll be happy to have a dialogue or do any individual coaching offline.
Roger, can
Yes.
I say something?
Yes, ma'am.
I think one of the things maybe we worry a bit about as an ACH is that in creating a change plan, and I'm just being honest and transparent, just to like recognize dynamics of the change plan, it is adding a lot of things, right? So what you just described of like adding, I'm like, well, okay. Some people might be thinking that that's what we're doing with the change plan. So how do we help? And I think, you know, that's one of the reasons we want to develop a coaching network, is to provide more support to help organizations pause or help organizations take smaller chunks. But do you have any advice around the change plan, around sequencing or starting small, just so that people don't spin their wheels and that we as an ACH don't contribute to failure because of being overwhelmed?
Yeah, absolutely. So, yeah, and I think a key most of it with respect to the change plan is how does it align with work that you are already doing or intending to do? There's already an existing body of work that aligns, and you have been able to piece together that messaging staff so they understand the strategic importance. That's one piece. Sometimes we're doing the same thing, but we label it a little bit differently. You want to make sure that it's in alignment. Then secondly is being very clear on your priorities and taking that pulse and temperature of the organization on how we're doing. Where possible, spreading the work across multiple pods or entities in the organization and not hurrying one organization. Not scaling too fast all at the same time. So going after those early adopters, letting them burn in and test, and then letting that spread through the organization through that guided natural process, rather than instant scale. Okay, what we just learned out of this behavioral health plan, we're scaling to the whole organization. That's going to be probably a belly flop. It's going to be a challenge unless you really plan. How are you packaging? How are you lining it? How are you connecting it to the why, the training program, and what's the spread target? So a combination of priority setting, alignment with existing, and carefully connecting the dots so people see the value, and then feeding back how is this connecting to our dots moving as an organization, our overall measures improving, our cost going down, whatever those key metrics are. That helps.
Even CACH is really also setting the pace too, that if we look at the future of where healthcare is, we have to have measurable goals. There's things that we've done that burn a value, and that without having specific targets like this, then we are moving forward. What he was talking about is that there are things that we've done that have been on ventilator and now we're really targeting our goals, those things that really have specific target outcomes, but also that are really identified by what the is.
So let's use that as a segue to apply this theory to asthma. So after the last meeting, we spent some time on the web looking at what data are available for your 4-county region. That would be a starting point in the environment. So discovered that there's a statewide asthma plan and that there are some data. Unfortunately, the data are old. See, that goes back to 2008, 2010, so that's 7 or 8 years. You know, there's an old saying that all models are wrong, most models are useful. So all data are wrong, most data are useful. So there are some data that are presented here. I want to have 2 discussions around the data. One is, did you learn anything out of this data? Anything stand out? There are a couple things that stood out for me, but I want to hear from you. And then 2, what data do you have available that can help inform this that might be more current? Where can we get some current data that'll help validate our planning assumptions and priorities? So for those of you that had a chance to look at the data, anything stand out for you? Anything pop out of the data? I'll go through the slides quickly. You'll see there's color coding. So the darkest color is the highest prevalence. So this is adults with current asthma by county. So Okanagan has the highest, and Douglas. Chelan and Grant are lower color.
I think it'd be interesting to throw in average family income, because as a rule, rates of smoking, obesity tend to be higher for lower income. Maybe I don't know, but if Okanagan, you know, seems to be the worst off, also has the lowest, you know, maybe that's the correlation we should be looking at. Maybe not so much doctor's offices, but social determinant kind of stuff.
Yeah, we could spend a lot of time beating up our care teams on following the latest asthma guidelines, and we may be missing the point. I was in Louisiana last week with the Secretary of Health, and they have a statewide colorectal screening initiative and breast cancer. And she reported to the group, she says, you know, we have the worst incidence in syphilis per population right now. It's exploding. And you know, people say, well, where do you even start with that? And she said, you know what it comes down to? 90 women. That's something you can do something about. You could put a nurse in a van and with antibiotics and go out and treat those 90 women and shut down the epidemic, right? So it's really important to understand your data and look where you can have an impact. That income would be an issue, and you mentioned smoking. So it turns out cigarette use is also higher in Okanagan. That one has the highest incident. It also correlates with that.
Also, your other counties that are pretty poor counties also almost directly correlate as well.
So income.
Poverty.
So obesity is related to asthma incidence, especially with children. So higher obesity rates. Interestingly, Grant popped up there rather than Okanagan as a leader. This one stood out to me. The Black population having a significant higher incidence than the rest of the population. Now, whether that's sustained over the decade or not is a question. But any insights on why that might be?
I'm guessing that part of the problem, especially in urban communities, is that places where they can afford to live are probably next to smelters and industrial areas and things like that, and the air quality is probably not as good.
Yeah. So in Camden, New Jersey, Jeff Brenner and his group came up with the concept of hotspotting, and they looked at their asthma data and were able to drill down, and it happened to be a very poor African American community. When they looked at it, it all circled around a couple of housing units. And when they went into the housing units, there was mold rampant throughout the housing units. So their intervention was to address the mold in those units, either displace the people or fix the buildings up to decrease the asthma rate. So are there any opportunities? You know, could we geocode some of the data? Can you go back and look at your data, people with asthma, and geocode where do they live? Maybe something will pop up here that just next to a smelter, or there's some other environmental cause that we need to be thinking about. Any other Any other aspects? So we saw the race was one. Air triggers. For a series, particulate matter. Any reason why Okanagan would have, and Chelan would have such high particulate matter? Fires.
That's number of things, right?
So air quality time due to the fires. Now this is 2010.
Probably worse.
Probably worse now. Huh? All right. Here's another one. This is something that is actionable. How many of the patients actually receive information on self-management by our care teams in the system? What we see is that people, how many are getting received an explanation on how to recognize early symptoms? 40% or not. What to do? Taught how to use a peak flow. Only about 40%. Written asthma plan. 20-some%. So 70-some% are not getting a written plan. That's something that's actionable that care teams could do across the environment. Youth with an asthma plan. 40-some% do not have an asthma plan for those diagnosed with asthma. So an opportunity to engage the family, engage the patient, and trying to figure out what some of the root causes in their environment. What's driving some of their issues. No PCP. So how many patients are coming through the ER? So there's, I think, 20% of youth had asthma at least one ER visit. So 20% are coming in. How many of them are coming in and don't have a doctor where we could connect them to a potential primary care provider and one of the systems in the environment? To pick up, right, as a larger environment, trying to find ways to connect people. That translates also to a business case for those primary care organizations, potentially depending upon the funding source. Adults missing work due to asthma. So there's a business case there for how many patients are missing work due to their asthma or their children's asthma potentially. And this is an opportunity to potentially engage the employers in the region, especially if there are a workforce data saying that maybe near a smelter who are having a very high rate of asthma, that could be causing a high absenteeism rate. We just don't have any data right now to know whether that's an issue, but that could be a compelling issue for some of the employers. Children missing school days. 20% of the kids in 8th, 10th, 12th grade are missing school days because of asthma. That could be a metric that we could see move over time if there was a regional effort. So what are your thoughts in terms of data and getting data and what data might be available? Do we have any payers on the phone? Do we have a payer in the room? And she was texting back saying, get me that asthma data as quickly as possible. Not to put you on the spot, but I think the payers are a rich source of being able to look at their data at a macro level. What do we know about where people with asthma? Is there any information? Any thoughts on data that might come from the payers?
This is Vicki Evans from Molina. I think that we can certainly, as long as there's been diagnosis codes submitted, we can certainly pull those. So we can pull data regionally to look at either incidence or follow up in that. So I think we just need to be specific to make sure in advance we look at what the information is a provider or providers or region wants so that we can set up and configure that to pull.
I don't want to speak for Dr. Coldy or Dr. Wilson, but I'm willing to bet that information located in various EMRs are a lot more accurate because trust me, there are patients who are seen for asthma and that's not going to show up in a diagnostic code.
I mean, what do you mean by that, Dave?
I mean, somebody may have come in for something else. By the way, my asthma's acting up. Doctors are so busy, they don't always put in every little thing that they've done, especially if they did it up here. And I think there are more people with asthma, or there are more services provided to people with asthma than are going to show up in the in the build information.
So there may, the claims data may not be as sensitive as the EMR data, but both could help inform if there's some hotspotting or something that we find there's clusters of people, even through encounter data. So we could get both, that would be helpful.
Now, he's going to say disagree or something.
No, I think you could actually extrapolate that to everything in medicine. Every problem.
You know, one thing I think is the fidelity of the EMR in terms of the sensitivity for picking up what's going on in the room is not that great, David. I think you're right on. And that's one of the arguments for using scribes and things like that to actually improve the accuracy of the coding and documentation of what's done, because a lot of times you're dealing with so much you just can't write it all down or remember what you did. It's a big challenge.
Would it be feasible to ask the participants in this room as a homework assignment to go back to whatever data you have available in your organizations and look at your population of patients and see what the data tell you in terms of who are those that have asthma? Where do they live? Is there any geocoding possible to see whether there's clustering of the population in certain areas that might give us a hint of some potential hooks of where we might be able to do some intervention? Is that feasible?
I'll find out.
You'll find out? You're willing to at least find out?
I know we can pull some questions out, but I just don't know about the asthma.
It all really has to do with what question you're asking. Are you asking how many do you have? Most people probably could figure out how many patients they've treated with asthma in the last year. Say, you could define the question, but maybe the more, there's other questions, that we get into where do they live or our zip codes are so big that doesn't really help much. But it may be what time of year. If all the asthma exacerbations are showing up in July and August when the smoke is elevated, particularly high, then do we do an action plan around what do we do in the summertime? Asthma exacerbation. But those are you have to know what question you want to ask in order to pull the data and just find out whether you have data to pull.
So if we circulate a question set to start,
sure,
and people can at least take a crack and see what's available. If you can't get it, you can't get it. With the collective resources in the room, we should be able to start to get a picture and some insight. And for those on the phone, you're not left out of this. We should be able to start to see a little bit more fidelity in terms of what are the real issues of asthma in the region, and see what we can find from that. Does that make sense to the group as a starting point?
I would think employment would also be an issue. In looking at the particulate matters per Okanagan, I'm thinking immediately of the orchards where they're dealing with dust and pesticides and things like that that probably have an impact on them.
Our numbers might have improved now that Alcoa closed, because my son-in-law developed severe lung problems after working there just 6 months. Breathing problems. Now it's permanent.
One thing I'd consider doing is looking at albuterol prescriptions or refills, because one thing I notice a lot is patients who have undiagnosed asthma that's being treated without being thoroughly documented.
Okay, that's great.
Except for how often are albuterol given for URIs acutely, just,
right,
over that cough, and you're using it for one time only.
Right, that's why I said maybe look at refills.
Yeah.
Okay. All right, we'll put a question set and circulate it. One thing I wanted to introduce for a future discussion, this hopefully are going to lead us to starting to narrow down where might we make some interventions. Now, in the handout we sent ahead of time, I had collated a set of change packages in the environment of what others are doing to try to address this. So some tangible things that could be done. Not going to go into these today, but I do want to offer you hope that this isn't an abstract exercise, that there are groups in other environments that are taking tangible things, working with payers, working with hospitals, working with clinics, working with community providers, all trying to address the issue. But I did want to spend some time today, and we'll come back to those change packages, is to talk about a strategy map. And I'm going to stand up and use technology here. I'm going to ask you, I'll go through this real quickly. I'm going to ask you, is there a, well, let's do, sorry. So this strategy map is work that was done on obesity, I believe, in San Diego. And they've outlined the target population. It's kind of difficult to see. But in this, they have taken the major stakeholders and outlined some specific initiatives of what could be done. So for example, Mayo had some great success in addressing asthma by working with nurses in the school system that were really the primary contact with the students and helping them self-manage and getting kids on medication and elsewhere. So engaging the school systems as part of the effort is an example. What I'd like to ask you is what community assets exist out there that as we move forward, we can start to catalog and build together kind of a coalition working on asthma in the community to move those numbers up. So what resources exist in the community that might be leveraged or should be brought to the table to start to influence the environment around asthma? What comes to mind? I mentioned schools.
Joanne Douglas Health District.
So public health for the 4 counties, that they may have interventions and things going on that already could be leveraged. Schools might have programs already going on.
What about the pharmacies? We could look at the number of refills for albuterol.
So actually reaching out to the pharmacies or the pharmacy chains to see what data might be available. What are they doing? Are they providing any education as patients and families are coming in?
Who controls the burning ban?
The burning ban?
Burn stuff.
Do they have an
EPA
air
or-
quality control office in town?
It's terrible. Welcome, Rick.
Air quality control office?
I used to have a PE teacher that called them every morning to complain about the smell. That was an everyday thing.
Other thoughts? Who else is in the environment to bring to the table potentially to start to look at who could really come and leverage the existing resources, knowledge, information, activities to influence asthma in the environment?
I'm not sure who manages our smoking cessation plan.
I would say smoking cessation.
Right.
Any others? What comes to mind? Anybody on the phone? Any resources in the environment?
Somebody who's really passionate about reducing asthma symptoms. I mean, I don't know who that would be, but that's, you want to get somebody to get everybody jazzed about this.
So your story is an example, and you talked about your son, and there was a little bit of passion in your statement that this had a real impact on my family, right? My son, working at this plant. So those kind of stories that can really connect people to the why.
What about
David was saying.
coaches and people who lead teams?
Part of that's through the schools, but also through Parks and Rec.
Parks and Recs, or
Yeah.
Any others?
Ramona in Grand Coulee. And one of the things that we have here is a number of people who do not have any other source of heat but wood burning. And so I don't know quite where that would fall into helping people find more efficient wood stoves, better air circulation. Some of them, we have a high level of poverty, so even having electricity is maybe very iffy proposition. That's most people eat with wood, so that's another area of concern.
And we're not eliminating the healthcare, like emergency rooms, primary care. I don't see any of us on there, but.
Yeah. And we've assumed that the delivery system, ER providers, primary care providers, all of you in the room, we'll be working on this and figure out how to leverage that across the environment. Other stakeholders that come to mind.
MCOs, public health or public housing.
Public housing?
Yeah,
Oh, yeah,
like
housing
mites and cleanliness of the areas and dust. MCOs.
MCOs, yep. Anybody else that comes to mind?
Employers who might be impacted by losing them.
Yep, employers.
Days,
Our stats affect the economic development portion too.
So Chamber of Commerce or some groups like that. So in the interest of time, what I'm going to suggest is that we start a landscape map, strategy map of who the stakeholders are. We'll ask that if all of you can go back and do your homework on what can we learn about asthma of the populations you serve, what data you might have available. We'll start a question set to get that out to you. Ask the MCOs to see if they can help us with looking at data for the 4-county region and what do we learn from those populations. Is there any clustering? Is there anything that attributes, demographics, or anything that stands out from a population health perspective? The next step also with the strategy map will be to reach out to these various stakeholders and see what programs are in place. Are there things that they're already doing? The MCOs might have materials they're giving out to their patients on managing asthma. Those of you that are providers also may be giving out materials. So what exists already, we don't have to reinvent the wheel, that might be able to be leveraged. And then looking at other environments, are there interventions that we might be able to address? You mentioned wood burning stoves. There's a initiative that was done in South Carolina where a group got together in a coalition and they went home by home and addressed sanitation and put plumbing that didn't exist before. And it was on the docket to do that through the state. So they were able to raise the funds and make that happen and address a lot of public health issues. I'll send around a case study in England where a single lady did this and addressed heating in the homes. We were able to get heating into a huge number of homes in a very impoverished area. So what may sound like impossible, actually people have done. So where there's a will, we can leverage that. Any questions for where we are today and where we'll be going next? So next we'll review the data of what comes in. We'll prepare a more refined strategy map and we can continue to build on to that. And we'll start to look at what interventions might be able to be feasible. And that could include some future sprints or lands or other activities of all the providers in the room. See what we could do as a concerted group to move that one indicator. Any questions? Any questions on the phone? And Wendy, I think I'm on time.
You are, thank you. I would add childcare